colon and rectum. Question and answer session. Welcome to today's podcast, where we discuss the main aspects of surgical management of benign pathologies of the colon and rectum. Our conversation is structured in a question and answer format to support medical students, surgical residents, clinicians, and all listeners interested in the surgical management of benign pathologies of the colon and rectum. Pause the podcast after each question to attempt answer. Let's begin. Large bowel obstruction question. What is the definition of large bowel obstruction? Answer. Large bowel obstruction is a blockage in the large intestine, occurring after the ileocecal valve. Question. How is large bowel obstruction classified? Answer. Large bowel obstruction is categorized into mechanical, dynamic, and functional, adynamic or pseudo-obstruction types. Question. What are the types of mechanical obstruction in the large bowel? Answer. The types of mechanical obstruction include endoluminal, mural, and extraluminal causes. Question. What are common causes of mechanical large bowel obstruction in different regions? Answer. Colorectal cancer is the most common cause in the United States, while colonic volvulus is more common in Russia, Eastern Europe, Africa, the Middle East, and India. Question. What is the prevalence of volvulus in large bowel obstruction worldwide? Answer. Volvulus is responsible for approximately 1/3 of large bowel obstruction cases worldwide. Question. How does volvulus cause large bowel obstruction? Answer. Volvulus causes obstruction through axial twisting of the colon around its mesentery. Question. What are the symptoms of mechanical large bowel obstruction? Answer. Symptoms include increased peristalsis, low-grade colicky abdominal pain, failure to pass stool and flatus, and progressive abdominal distension. Question. How do acute and progressive mechanical obstruction present differently? Answer. Acute obstruction presents with rapid onset of pain, distension, and abdominal tenderness, while progressive obstruction is characterized by increasing constipation, pencil-thin stools, and intermittent abdominal pain. Question. What are the symptoms of functional large bowel obstruction? Answer. Functional obstruction presents with abdominal distension, vague abdominal pain, and weak or absent bowel sounds. Question. What is closed-loop obstruction in the large bowel and why is it significant? Answer. Closed-loop obstruction occurs when both ends of a bowel segment are blocked, increasing the risk of bowel ischemia and perforation. Question. What are the most common causes of closed-loop obstruction in the large bowel? Answer. The most common causes are volvulus, twisting of the bowel, and strangulated hernias. Question. What imaging findings are associated with large bowel obstruction? Answer. Plain abdominal X-ray may show a large, gas-filled loop of colon. Coffee bean sign, and computed tomography scan may reveal a mesenteric whorl. Question. How does the competence of the ileocecal valve affect colon cancer-related obstruction? Answer. A competent ileocecal valve can cause a closed-loop obstruction with a more acute presentation, while an incompetent valve allows backflow, resulting in a less severe presentation. Question. Where do most colon obstructions occur and why? Answer. Most obstructions occur in the left colon, due to the circumferential growth pattern of tumors in this region. Question. How do right-sided colon tumors differ from left-sided tumors? Answer. Right-sided colon tumors are generally more polypoid in nature compared to left-sided tumors. Question. What causes distension of the colon in large bowel obstruction? Answer. Distension is caused by the accumulation of gas and stool proximal to the site of obstruction. Question. Where does the gas in large bowel obstruction originate from? Answer. The gas originates from swallowed air and bacterial fermentation. Question. How does increased pressure in the bowel wall affect the intestine in large bowel obstruction? Answer. Increased pressure can lead to ischemic necrosis and perforation, often occurring in the cecum because of its larger diameter, as described by the law of Laplace. Question. How can hernias lead to bowel ischemia in large bowel obstruction? Answer. Pressure on the mesentery caused by hernias can obstruct blood flow, leading to ischemia and necrosis of the bowel. Question. How does distension progress in closed-loop obstruction of the large bowel? Answer. Distension begins in the trapped bowel segment and progresses proximally due to the continued accumulation of gas and stool. Diagnosis and assessment. Question. What is the diagnostic approach to large bowel obstruction? Answer. A thorough history and physical examination are essential for diagnosing large bowel obstruction. Question. What information should be gathered during history taking for large bowel obstruction? Answer. Important information includes symptom onset, progression, underlying medical conditions, medications, and recent endoscopic procedures. Question: what should be included in the physical examination for large bowel obstruction? Answer: the physical examination should include abdominal palpation for masses, tenderness, and scars, examination of the groin for hernias, and digital rectal examination for neoplasia and fecal impaction. Question: how does abdominal X-ray help in the assessment of large bowel obstruction? Answer: abdominal X-ray helps localize the obstruction, assess the degree of distension, and evaluate the function of the ileocecal valve. Question: what information does a computed tomography scan provide in large bowel obstruction? Answer: computed tomography scan provides detailed information about the location and cause of the obstruction, including diverticulitis, inflammatory bowel disease, and extraluminal causes. Question: what are the advantages of computed tomography imaging in large bowel obstruction? Answer: computed tomography imaging is detailed, quick, and safe, and it helps identify the site and cause of obstruction as well as the competence of the ileocecal valve. Question: what contrast options are used in imaging for large bowel obstruction? Answer: rectal contrast is often preferred for detailed imaging, and water-soluble contrast enemas can be used for both diagnosis and therapy. Question: how can computed tomography imaging be used in cases of colonic obstruction? Answer: computed tomography imaging can provide clues regarding tissue ischemia and impending perforation. Question: what is the role of flexible endoscopy in large bowel obstruction? Answer: flexible endoscopy assists in diagnosing obstruction, collecting biopsies, and performing therapeutic procedures such as detorsion and stent insertion. Question: why are basic blood analyses important in large bowel obstruction? Answer: basic blood analyses are crucial for initial assessment, helping to diagnose electrolyte abnormalities and assess the severity of the condition. Question: what is the significance of elevated biomarkers in large bowel obstruction? Answer: elevated levels of white blood cells, C-reactive protein, lactate, base excess, and decreased pH indicate a more severe condition and help guide the aggressiveness of treatment. Treatment question: how is the treatment approach for large bowel obstruction determined? Answer: the treatment is customized based on the underlying cause of the obstruction. Question: what factors influence the choice of treatment options for large bowel obstruction? Answer: treatment options depend on the cause, suspicion of bowel ischemia, risk of impending perforation, patient's overall condition, and comorbidities. Question: when is surgical intervention indicated in large bowel obstruction? Answer: surgical intervention is necessary for patients exhibiting signs of peritonitis, perforation, or ischemic bowel. Question: why is prompt relief important in mechanical large bowel obstruction? Answer: prompt relief is crucial to prevent bowel necrosis and perforation. Question: what is the initial management for sigmoid volvulus in large bowel obstruction? Answer: endoscopic decompression is the first-line treatment, followed by surgery if decompression fails or to prevent recurrence. Question: how are cecal volvulus and inflammatory bowel disease-related obstruction managed? Answer: cecal volvulus is typically managed with primary resection and anastomosis, while inflammatory bowel disease-related obstruction often responds to steroid therapy. Question: what is the treatment for pericolic abscesses associated with large bowel obstruction? Answer: percutaneous drainage is the treatment of choice for pericolic abscesses. Question: how are foreign bodies in the large bowel managed? Answer: foreign bodies are removed using endoscopic techniques. Question: what is the recommended approach for treating adult colonic intussusceptions? Answer: surgical resection without reduction is recommended, as adult intussusceptions are often associated with a pathological lead point. Question: what are the benefits of colonic stents in the management of large bowel obstruction? Answer: colonic stents can relieve symptoms, optimize patient condition, and allow for preoperative chemotherapy. Question: when are colonic stents used in the management of large bowel obstruction? Answer: colonic stents are used to manage obstructing colon cancer, especially in high-risk surgical patients or those requiring palliation. Question: what is the role of colonic stents as a bridge to surgery in large bowel obstruction? Answer: colonic stents can serve as a bridge to surgery, potentially enabling single-stage operations and avoiding stoma formation. Question: what are the complications associated with colonic stents? Answer: complications include stent migration, perforation, and reobstruction. Question: What does current evidence say about the efficacy of colonic stents for large bowel obstruction? Answer. Trials and meta-analyses report mixed results regarding morbidity, mortality, stoma rates, and long-term survival for colonic stents. Question. How should treatment decisions be made for patients with large bowel obstruction? Answer. Treatment decisions require individual assessment, taking into account patient health, tumor characteristics, and available resources. Question. What surgical procedures may be performed for large bowel obstruction? Answer. Procedures include segmental resection with Hartmann's operation or primary anastomosis with or without a diverting stoma. Question. When is subtotal colectomy indicated in large bowel obstruction? Answer. Subtotal colectomy is performed if the cecum is ischemic or non-viable. Question. How is right-sided large bowel obstruction treated? Answer. Right-sided large bowel obstruction is treated with right hemicolectomy and primary anastomosis. Colonic pseudo-obstruction. Question. What is acute colonic pseudo-obstruction, also known as Ogilvie syndrome? Answer. Acute colonic pseudo-obstruction, also called Ogilvie syndrome, is a condition characterized by sudden colonic dilatation without evidence of mechanical obstruction. Question. How common is Ogilvie syndrome? Answer. Ogilvie syndrome is rare, with an estimated occurrence of 100 cases per 100,000 hospital admissions. Question. What is believed to cause colonic pseudo-obstruction? Answer. Dysregulation of colonic autonomic innervation is thought to be a key factor, with possible mechanisms including autonomic imbalance, disrupted colonic reflex arcs, chronic disease, and certain medications. Question. Which patients are most commonly affected by colonic pseudo-obstruction? Answer. Colonic pseudo-obstruction most frequently affects elderly patients and those with multiple comorbidities. Question. What are common precipitating factors for colonic pseudo-obstruction? Answer. Acute illnesses and underlying neurologic, cardiac, or respiratory diseases are frequent precipitating factors for colonic pseudo-obstruction. Diagnosis. Question. What is the typical patient profile for colonic pseudo-obstruction? Answer. Elderly individuals with multiple health conditions, often hospitalized for acute medical issues or recent surgery, are typical patients for colonic pseudo-obstruction. Question. What symptoms are commonly seen in colonic pseudo-obstruction? Answer. Common symptoms include abdominal distension, pain, nausea, vomiting, and obstipation. Question. What tests are part of the initial evaluation for colonic pseudo-obstruction? Answer. Initial evaluation includes complete blood count, serum electrolytes, renal function assessment, and diagnostic imaging such as plain abdominal radiographs. Question. How does colonic pseudo-obstruction present on imaging compared to mechanical obstruction? Answer. Colonic pseudo-obstruction typically shows dilation and gas throughout the colon, including the distal rectum, whereas mechanical obstruction often results in little gas distally. Question. What is the standard confirmatory test for colonic pseudo-obstruction? Answer. Abdominal computed tomography is the standard confirmatory test, which helps distinguish the type of obstruction and assess for signs of ischemia and perforation. Question. What indicators suggest colon ischemia or perforation in colonic pseudo-obstruction? Answer. Abdominal tenderness, leukocytosis, fever, and cecal dilation over 12 cm may signal colon ischemia, perforation, or impending perforation. Question. What conditions should be considered in the differential diagnosis for colonic pseudo-obstruction? Answer. Conditions to consider include mechanical obstruction, toxic megacolon due to Clostridium difficile, and toxic megacolon from other causes. Management. Question. What are the treatment options for colonic pseudo-obstruction? Answer. Treatment options include supportive care, pharmacologic therapy with neostigmine, endoscopic decompression by colonoscopy, and surgery. Question. What is the initial intervention for colonic pseudo-obstruction? Answer. Rectal tube insertion is used for decompression, providing temporary relief while the underlying cause is addressed. Question. How should rectal tube insertion be performed in colonic pseudo-obstruction? Answer. Rectal tube insertion can be done at the bedside, but careful technique is required to avoid injury to the rectal mucosa. Question. What is the recommended non-operative management for colonic pseudo-obstruction? Answer. For patients with a cecal diameter less than 12 cm and no signs of ischemia or perforation, supportive care includes nothing by mouth, correction of electrolyte imbalances, discontinuation of contributing medications, and possible insertion of nasogastric and rectal tubes. Question. What are the complications of colonic pseudo-obstruction? Answer. Ischemia or perforation can occur in 3 to 15% of cases, with a mortality rate approaching 50%. Question. When is colonic decompression indicated in colonic pseudo-obstruction? Answer. Colonic decompression is indicated for cases that do not improve with supportive care, when the cecal diameter is greater than 12 centimeters, or when there is no systemic toxicity and abdominal tenderness. Question. How effective is neostigmine treatment for acute colonic pseudo-obstruction? Answer. Neostigmine is a safe and effective option for acute colonic pseudo-obstruction, with reported success rates between 60 and 94%. Question. How is neostigmine administered for colonic pseudo-obstruction? Answer. Neostigmine is administered as a 2 to 2.5 mg intravenous bolus over 3 to 5 minutes, leading to strong colonic peristalsis. Question. What alternative treatment is available for patients who cannot receive neostigmine or do not respond to it? Answer. Endoscopic decompression is an alternative for patients with contraindications to neostigmine or those who do not respond, with a high success rate of 61 to 95%. Question. When is surgical intervention required for colonic pseudo-obstruction? Answer. Surgical intervention is required for patients who do not respond to other treatments or who show signs of systemic toxicity, ischemia, or perforation. Question. What surgical options are available for colonic pseudo-obstruction? Answer. If the colon is viable, tube cecostomy or cecostomy can be performed. If there is ischemia or perforation, resection is required, often with a diverting stoma. Question. What factors influence surgical decisions in colonic pseudo-obstruction? Answer. Surgical decisions are influenced by the viability of the colon and the overall condition of the patient. Pelvic floor disorders and constipation. Question. What are pelvic floor disorders and how are they managed? Answer. Pelvic floor disorders encompass various conditions that often require a multidisciplinary approach involving colorectal, urologic, and gynecologic specialists. Question. What is constipation and what conditions may be associated with it? Answer. Constipation is a dysfunction of colonic motility and defecation, potentially associated with medical and colorectal conditions such as colon obstruction and pelvic floor diseases. Question. What is functional constipation and when might surgical intervention be considered? Answer. Functional constipation requires differentiation from anatomical issues and may be considered for surgical intervention if it does not respond to medical management. Question. What are examples of pelvic floor disorders? Answer. Examples of pelvic floor disorders include rectal prolapse, rectocele, cul-de-sac hernia, and anismus. Question. What is rectal prolapse? Answer. Rectal prolapse is a circumferential, full-thickness intussusception of the rectum. Question. What is a rectocele? Answer. A rectocele is a bulging of the rectum into the posterior wall of the vagina. Question. What is a cul-de-sac hernia? Answer. A cul-de-sac hernia is a protrusion of the peritoneum between the rectum and the vagina. Question. What are the types of cul-de-sac hernias? Answer. There are two types of cul-de-sac hernias: enterocele, which contains small bowel, and sigmoidocele, which contains sigmoid colon. Question. What is anismus? Answer. Anismus is the failure of the puborectalis and external anal sphincter to relax during defecation. Question. What is the role of surgeons in managing functional pelvic floor disorders? Answer. Surgeons are almost always involved in evaluating patients with functional disorders and establishing a treatment plan. Question. Do functional pelvic floor disorders always require surgery? Answer. No. Functional disorders do not always require surgery. That's it. Thanks for tuning in. If you enjoy our content, please like, share and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.